Good afternoon and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend some time with us, and we are going to have a very interesting conversation this afternoon on something that, well, I won't try to quote the statistic, but most of us are dealing with, and I'll leave it at that. Without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone. Dr. Neighbor Stevens, Dr. Hines, and Dr. Walks, and our special guest, who I'm going to introduce in a minute. But before I do that, I want to remind everybody that we do stream live on Facebook, and we also have live broadcasts on YouTube, and we archive all of our talks on YouTube. So this is made for the lay audience, even though we have certain physicians who join us. So we're very happy to have you with us. I want to start. We just had a praise report when we first started of somebody working on their cholesterol. You want to give a 1-minute praise report? Is she still on? Can you unmute him, Simon?
Oh, who am I unmuting?
Okay, we can do it later then. We can't do that. So the special guest that we have today is somebody that I always talk about how long I've known Dr. Barbara Neighbors Stevens. And I met Barbara Neighbors Stevens, I believe, when I was in medical school working on my doctorate. But our guest speaker today, I think I met when I was either 4 or 5 years old, and his uncle lived across the street from where I lived. And we played in a sandbox, and I remember he broke one of my trucks. So we've been for a long time. Dr. Michael Lenore is an MD. He's an allergist and a pediatrician who has practiced pediatrics and clinical allergy full-time since 1977. He received his medical degree from the University of Texas in Galveston. He is board certified by and a fellow of both the American Academy of Pediatrics and the American Academy of Allergy, Asthma, and Immunology. He has served on the board of the American Association of Certified Allergists. In 2014, Dr. Lenore was elected the 114th president of the National Medical Association. Dr. Lenore is an associate clinical professor at UCSF. He has served as the chairman of clinical faculty. For 20 years, he was the director of allergy services at San Francisco General Hospital. And he has a special interest in asthma and the African American and high-risk communities and gender polymorphism. I introduce you, and it's my great pleasure to introduce my colleague, Dr. Michael A. Lenore. Dr. Lenore, the floor is yours.
Oh, well, thank you very much. I want to, congratulate you on what you've done, not only during the pandemic, but through the years, and say thank you. The information that you've been giving out almost on a weekly basis, having had radio programs for every week, I know how difficult that is. And so I'd like to say thank you for the audience that you have among the physician community and among the people that listen to your program. So not knowing what the format is, I think obviously you've got a number of doctors, people here who may have questions. How do you want me to proceed? I can tell you a little bit about why we're here now, because if you're wheezing and sneezing, it's allergy season. And this year things are going to be much worse in California and probably in many parts of the country. California, our season is a little different from other parts of the country. We have a season that starts in January, pretty much ends in July. Whereas in the Midwest and the East, you have seasons that start later or shorter in the spring, but you also have ragweed seasons, and everybody else comes to California, but ragweed does not. And so consequently, this year's going to be a big year because it's been raining here as long as I could remember, almost in Noah's Ark-like fashion. So we expect an awful lot of pollen. And when you have pollen this time of year, obviously you have the overreaction of allergy, which is what allergy is. So you can expect that the next couple months, and certainly the peak is in May in California and probably in most of the country, to see the pollen counts go up and the hospitalizations and increased doctor visits for allergy go down. When we talk about what we call quote, the pathophysiology of allergy, that means why do we have allergy? Because allergy is actually an overreaction. It's probably not as simple as you think because there are basically 4 types of allergy, and they're couched a little differently. The one we're talking about is a type 1 allergy in which you have an antibody and an allergen come together and release certain chemicals. The primary chemical being histamine, which causes the vessels to swell and leak fluid and the airways to close down. But you may not think about it, but diseases, autoimmune disease is a type of allergy. And certainly eczema, which is, and other skin reactions are also different types of allergy. But the pollen allergy we're talking about now is really mostly the type 1 allergy, in which you've made an antibody to grass, trees, and weeds in the fall. And that's what causes the difficulty. And so clinically, about 20% of the population has the capacity to have allergy. It seems like everybody has it, but that's not really quite true. There are a lot of things that mimic it. If you look at what causes allergy, in addition to pollen, there are inhalants and non-inhalant allergens. The inhalant allergens are grasses, trees, and weeds. The non-inhalant allergens are house dust, mold, animal dander, and foods. And so consequently, each of these has the capacity to cause this reaction, but it's dominated this particular point in time by pollen. So that's my introduction.
Well, thank you so much. So being one that has allergies, and my whole family, we have allergies, and probably me more than anybody else, mainly to dust and pollen. What's the best approach to that, Mike?
Well, I think that allergy is kind of a cumulative thing. That means if you have just pollen allergy, then you have one level of disease. But if you have pollen allergy and then perennially you have house dust, dog, cat, and foods, then each one of those adds a different level of chemical burden and clinical symptoms. And so consequently, the first thing to do is to tighten up the allergies you already know about. The house dust, and the animals now. Animals are kind of a different thing. I don't like animals. I don't want them on coats, and I don't want to experiment it on. But I don't want them licking on me either, jumping on me. I'm not one of those people. But I've never, in all of my years in allergy, seen anybody give up an animal, no matter how bad the situation is. But this time of year, you don't want your dogs and cats outside bringing pollen into the house. And you don't want them lying up in bed like they're, alternate siblings or wives, and because they attract in pollen and they continue to add to the burden of allergies. So the first thing to do is to tighten up your environmental controls, especially the house dust. Get everything out of the bedroom you can, pillow and mattress covers, the drill. And it's difficult with chronic disease for anybody. I don't say compliance anymore because that's politically incorrect. People don't adhere as much as they should once they have allergy, because you get tired of doing all this stuff. But this time of year, because the burden that pollen puts on you clinically, the best thing to do is to really tighten up your environmental controls, avoid the foods cause problems, keep the animals out of the bedroom, and keep them mostly inside. A, because they have allergies as well, but B, because they track in pollen. The other thing is that, fortunately, from an allergy perspective, probably more good products have gone across the counter for allergy than have in other specialties. For instance, the non-sedating antihistamines like cetirizine, loratadine, Allegra, which is fexofenadine, they're all available across the counter. They have strong antihistaminic properties. They're really good because they don't cross the blood-brain barrier and they won't make you drowsy, although about 15% of people with Zyrtec do have some cetirizine do have some drowsiness. The nasal sprays that are across the counter are basically of 2 types. One of the nasal decongestants like Afrin and Sanya spray, those kinds of sprays are not particularly good to use because they do work for 2 or 3 days. But if you use them too long, there's a condition called rhinitis medicamentosa, where your nose becomes dependent on them. So you want to avoid those. But there's drugs like Flonase and Astropro and those kinds of preparations are specifically designed to be metabolized at the surface of the nose, not absorbed systemically, but available across the counter. Certain allergy eye drops are available now across the counter. So a lot of good medicines. So for those of you who have pollen allergy, the best thing to do is to start right now. And I don't usually recommend for people to take medicine unless they have major symptoms. But I would stay on that medicine until about the 1st of June, because it's going to be pretty bad out there for the rest of the year.
Well, I'd like to introduce Dr. Barbara Neighbor-Stevens, a fellow pediatrician, and I think she knows well a couple of ankle biters. Dr. Neighbor-Stevens?
Thank you so much. Dr. Lenore, when I talk with parents who have children with allergies and asthma, I always go through a fair amount of detail regarding measures that can be done. And it never ceased to surprise me that when I would go through the list, the dots hadn't been connected. For example, they would have teddy bears and drapes in the bedroom or curtains in the bedroom, and they would have rugs and carpets in the house. And it would take them by surprise that these would be problematic things to have in the house. They were rather proud of the decorating jobs that they had done, especially in the children's rooms when they had, done all of this decorating and stuff. So I know you addressed it when you said the tightening up of the household, but maybe you might want to go a little bit in depth and explain why these are problems.
Well, I think the fact that, as Black people, and I was talking to one of my patients the other day, she wanted an excuse from school because her child didn't like the food. And I told her we really don't give excuses like that. But, somewhere in your medical training, let's start with doctors, you believe in allergy or you don't. And if you don't believe in it, then you don't deal with patients at the level where they do understand the things that you describe. The second thing is very difficult to do the same thing every day. So I think it's really important when you give them advice, to give them advice that they can possibly keep. Because if you look at the sheets that we hand out for house dust control, for instance, you'd have to take a day off from work to do all of those things in order to reduce some symptoms from allergy. So I think just the fact that it's not, like I said, the other thing I told the patient was I had to be dying before I couldn't go to school. My mother wouldn't, you would have a temperature like 103. She wasn't going, you remember it was like Randall in Cincinnati, you went to school, the snow was 3 or 4 feet tall, you just got up and went. And the same thing is true for many, many households still today. They don't believe these symptoms are sufficiently disturbing to do all the intervention. And once they start, keeping it up does require some regular intervention by the primary care doctor. So I think the fact that doctors are not as aggressive sometimes about making the connections you make, and that patients don't perceive the symptoms of allergy more as an inconvenience than as a major chronic medical problem.
Thank you. Dr. Walks.
Good afternoon, Dr. Lenore. Thank you so much for the facility with which you send the information out. It's always great to listen to someone who knows things very well, and they just have it available top of mind. I used to be that way, and then my hair started turning gray, so I have to look for information sometimes. Let me ask this question. I have a good friend who's a physician that worries because his children protect the grandchildren too much. Don't let them get around this, and don't let them eat that, and don't let them get anywhere near any peanuts, and is worried that they will develop allergies because they're not exposed to things when they're very young. Does that have any relevance to pollen and to some of the things that you're talking about? Should we allow the kids, I won't say ankle biters, Dr. Maxey, should we allow the young people to be on the floor and to be around everything? Does that help them later on with allergy development?
That's a very, very pertinent question. I appreciate you asking it because we come full circle on this. I'm a little older than Dr. Neighbor, and I remember the days when we used to feed infants at 3 weeks, cereal in 3 weeks, and then we would go on from there. And now you say, well, that was kind of crazy. But then the American Academy gets involved and everybody starts studying things. And then we move it back to maybe about 6 months. Well, now we know, and I've always suspected, but now we really know that there are certain systems in the body, immunologic systems that are fully formed when you were born. And they start to remember what we call allergens the whole time, or antigens. And that's where the whole antibody, T cell, and non-specific immune system works. Well, there's one system that's not fully developed, and that's called the T system. So Th1, Th2. So if you're exposed to allergens, it turns out early on, before the age of 6 or 7 months, then you can develop a tolerance to the
What's
allergen.
the name of that system, Dr. Lenore?
It's called the Th system. It's a system in which you can go one way or the other. So if you're exposed to allergen early in that system, then it moves you away from allergy toward protection of infection. And so consequently now all of the food allergy information that we have suggests that if you've got a child who is at risk for developing food allergy, you got to feed them early, before 6 to 9 months, with that particular food or some form of that food substance. It's more fully developed in relationship to peanut. For instance, we used to say, well, if you're allergic to peanuts, just don't give them peanuts. That was always my particular form. But now we know that if you have a child who has severe peanut allergy, and you are a history of peanut allergy, evidence of peanut allergy, before that allergy becomes too great, and you feed them certain peanut substances, you can reduce the clinical symptoms associated with peanut allergy and some peanut allergy, and in some instances, you can eliminate it altogether. So now we're back to feeding infants earlier. And if the big thing, which is the theory on which all this was based, had to do with playing in dirt and dust. And it became clear from observations in Europe and other places that those children who were allowed to play, because when I was growing up, dirt was one of our friends. We didn't have all these bicycles and these little things you can look at and play on. We just went outside. And if you go, they showed that if you go and play in dirt, or you're exposed early to microbes, you have a much stronger immune system. And so consequently, now we're back to feeding infants a lot earlier now for that reason. There's a whole science now that I think is being, that eludes the Black community about food-related allergies and all of the things that can be done early with young children around food allergies to reduce the severity of it. There's still a lot of unknowns about how long that lasts and whether or not it's a permanent thing. That information is still evolving. But it's pretty clear that we're now back to exposing children to all kinds of things simply because that particular system can develop such it strengthens their ability to handle infection. If you don't do that, they develop a lot more allergies.
Thank you so much. That's what when I was referring to ankle biters, I wasn't talking about children. I was talking about the little bitty dogs that some people have. Dr. Hines, how are you?
Thank you, Dr. Lenore, for this very timely talk. I am an allergy sufferer as well, and over here on the East Coast, it's a big deal around this time of the year. And as a family doc, oftentimes when I would see patients and tell them that they likely had allergies, the answer I would get was, I can't have allergies because I've never been tested, right? So my question is really, what are some of the reasons currently why it might be worthwhile to get allergy testing?
Well, allergy testing is an interesting concept. Nowhere in medicine is there more room for physician creativity than deciding what to test for and how to read it. So consequently, testing is just ancillary to the history that you're taking. It's my contention that if you have no idea of what your patient might be reacting to, and you're not proposing to be more aggressive about the treatment, either the environmental controls or the medication, the testing will simply serve to confuse you. And so consequently, it's the history of exposure of cause and effect that really helps us to make the diagnosis. We do the testing because we want to nail down maybe some more specific issues. And if there's no history of a problem with that particular allergen, then it's just simply a test. And so consequently, we test because we anticipate we're not getting the result we want from the environmental controls and the medication. Or we're thinking that immunotherapy or hyposensitization may be warranted because we're not getting that effect. I do feel, though, that as a family practice doc or an internist, that if you ask the proper history, you engage that patient in the proper interventions to avoid those things to which you suspect. You use the appropriate medication. Very few people of your practice would have to be referred to an allergist. But let's just say that's less than 5%. That's enough for me to send children to college, on 5%. But I think that you, as a primary care doc, can probably intervene as effectively in allergy 90% of the time, intervene as well as I can.
Dr. Neighbors, anything in the chat, any questions from our audience?
There is a question, is it okay to be on a daily dose of loratadine and Flonase long-term?
It's probably okay, but the question is why? Why are you on those for that length of time? Why wouldn't you try to understand why those symptoms are developing? Why wouldn't you engage in an environmental control program? And why wouldn't you move forward to see if you could reduce the need for medication? I never talk to patients about the use of medication, either in my pediatric practice or my consulting allergy practice, without the fact that they should also, let's see, I've lost my train of thought, but without stopping the medicine. I always talk to them about stopping the medicine as part of the introductory and starting medicine. And that's true of those medicines that people tend to take on a regular basis. They need to be stopped if they can be. And the only way you know if they can be is because you've gone through the process of engaging the environment and doing the other things that you needed to do prior to thinking about continuing that medicine. So the answer is no, you could probably take them indefinitely, but you need more information.
Can you develop allergies later? I recall as a child where I lived in Madisonville, my backyard was like an orchard, and I used to live in those trees, and apples, oranges, bananas, we didn't grow those in Cincinnati, but all those same fruits that I ate with freedom then, they bother me now. They put a burn or pain in my mouth. How can I have developed an allergy to something I was exposed to so young?
Well, I think one of the saddest things, being a Black allergist, is to tell a patient they're allergic to seafood. I mean, it's like a tragedy. You know what I mean? Because seafood is such a heavy component of so many people's diets, and so that's one that that usually develops later in life. The development of allergy depends upon a couple of exposure and volume. So over a period of time, if you are eating a certain food on a regular basis, then you still have the capacity to react to it. In my clinical experience, it mostly happens with seafoods and nuts and strange fruits like kiwi or mango, things like that, things that you don't eat that often, but have high potential for developing allergy. One of the biggest confusions is this whole issue around milk, because there are basically two major reactions to foods. One is allergy, the other is sensitization. Now, allergy involves an immunologic component. That's the definition of what makes an allergy. Sensitization means it can mean a variety of different things, from esophagitis all the way down to large colon and rectal problems, IBS and colonitis. So that those two things are the things that, those are the two major reactions to foods. Now, lactose is the big, milk is the big, because if you are allergic to milk, that means you make an antibody to milk. If you're lactose intolerant, that means you lack the enzyme that breaks down lactose. The symptoms can be exactly the same, but the pathophysiology or the clinical nature of the problem is different. And so, I think with those two things are the reactions that we have to foods. Milk is where I think it becomes most confusing, but certainly you can develop allergy at any age.
So can I just jump in on the milk, Dr. Lenore, because so many folks that look like us say I have a milk allergy or I'm lactose intolerant. So they do make the lactose-free milk. So would that differentiate between the allergy and the lactose issue if you drink the lactose-free milk?
Yes, because what you're allergic to with milk is the protein. And so it has nothing to do with the lactose. So that you can take lactose-free milk, you can still be allergic because of the protein.
Okay. Thank you. Dr. Maxey, Dr. Gibson had his hand up. Dr. Sherrod has her hand up. So
Okay, let's unlock him, unmute him. Dr. Gibson? He's our resident pharmacist.
Dr. Gibson is still muted, and Dr. Sherrod is still muted. Oh, Dr. Gibson, there we go.
Thank you. Thank you. Excellent presentation, Doctor. I'm really curious to know what your feedback would be on the challenge of our young patients in Southern California that struggle with the poor air quality here, and whether or not that serious asthma problem we have in Southern California with our young patients is in any way an allergic response to the poor air quality. Question number one. Question number two is, you mentioned the TH system earlier. I'm also curious to know if B cell memory is something that we could really stand to talk about along with TH system, particularly as it relates to our people. Thank you.
Yeah, well, let's take the first question first. Well, remember, I said that there are basically two types of responses that people have with allergy. Some substances are allergic, some substances are irritants, and certainly the chemical reactions that we see with environment pollution is more an irritant than an allergen, but it can trigger major allergy-like symptoms. And so most of the problems we see with pollution are not related to allergy. They're related to irritants that are a combination as part of most pollutants. We know that young children who have asthma are much worse the closer they live to freeways. We know about environmental justice. We know that a lot of these dumps and oil things and things that we see in our communities are close to Black neighborhoods, and were built in Black neighborhoods, but it's more an irritant than an allergen. An interesting question about T cells, and to kind of give us a baseline. Remember, I said there are several types of allergy and several types of immunologic protection you have. Basically, you can divide it into two major pieces. One is those things that remember the allergen and those things that don't. I think that if the you may not remember this from your biology, but if the lamprey and the hagfish had it, that's important. That means it's a building block. And they don't have specific immunity. They have white cells, and they have skin, and they have other extracellular fluid that protect them with certain chemicals. Okay, so those things that remember the allergen can be divided into two groups. One is the group that makes antibodies. And antibodies have gotten all this publicity with the pandemic and with COVID. But as part of your protective mechanisms, then there's a whole different cellular component that are sensitized T cells that understand unique allergens. And they're very important in protection. And I think that they're often ignored because they're hard to duplicate. You can't gather them together like you can with immunizations for like COVID immunizations stimulate antibodies, also T cells, but the T cells can't be measured. But T cells are a very important component to your protective immunologic mechanism. And so the immune system's much more complicated than the antibody story we've been telling over the last 3 years. Because without T cells, you have some very serious immune deficiency problems. But you can't answer your question. You can't harness them like you can antibodies. And so it's still some of the research that's going on now is being more specific and targeting the trigger of sensitized T cells.
When you spoke earlier about the ingestion of milk and milk products and IBS and I believe colitis, am I to understand that you're saying those fit in the allergic response type categories, or?
Yeah, those are well, the two yeah, the type that we talked about with lactose, that's just a deficiency.
Hmm.
But when you talk about colitis or renal enteritis or eosinophilic esophagitis, any itis is really an immune response where the body attacks itself. And so the autoimmune diseases really fall into the category of type 2 allergy. Type 1 is the one with pollen. Type 2 is autoimmune diseases. Type 3 are the kinds of reactions you see in the hospital, like arthritis reactions, post-streptococcus, glomerulonephritis, those kinds of things. Or type 3 reactions. Type 4 reactions are T cell reactions. The most common one is eczema, graft versus host reactions. Those are T cell. Those are all T cell mediated. And so type 2 reactions can cause irritable bowel syndrome, renal enteritis, I could say some gastritis, certainly eosinophilic esophagitis. Those are all autoimmune reactions, type 2 immune reactions.
Thank you very much.
Thank you so much. Dr. Sherrod?
Oh, yes. Good afternoon, everybody. And it's good to see you, Dr. Lenore. Excellent lecture. My question is concerning the evaluation of patients with food allergies and the use of elimination diets. And can you comment on the tests that are now available for evaluation of patients with food allergies, like ELISA or Genova testing? And then we have under IBS and SIBO, the FODMAP diet. Are you familiar with all of these? And if so, can you kind of clarify how the approach to actually finding out what the patient food that the patient is allergic to and how to reintroduce that food? I understand some can be reintroduced through the elimination diet or the FODMAP.
Yeah, I think from my perspective, it's the history and physical of cause and effect that give you the most important information about food allergy. I think that many people think that foods cause every problem. For instance, if you ask most people what's the most common food that they encounter that causes allergy, they will say sugar. And that's usually their first response. Sugar's never caused any allergies. It's kind of more of a simple chemical, doesn't cause allergy. People are not allergic to sugar. Now, they may not be able to tolerate it for a number of different reasons. Or you go the other side, fatigue, inability to concentrate, hyperactivity, autism, all of them have been explained in the concept of allergy. But really, allergy symptoms are really pretty straightforward and of the type that we described. So when you start talking about diagnosing food allergy, you're really talking about taking a really good history. I think that's kind of the big thing with food allergy. Then, because food skin testing is like an exercise in creativity, like I said. I know some doctors put on 74 foods. I never put on more than 16 to 20. And so consequently, but those were to confirm my clinical impression that this child may have food allergy. But the ultimate diagnostic test is the challenge. That's true whether you're talking about penicillin or you're talking about oranges or apples or any one of the number of foods that can classically cause problems. And in challenges, what we do is we give small amounts, and we're very rigorous about how we record symptoms. And over a period of time, you could tell, I think in most instances, in many instances, whether that patient is allergic to that particular food. Challenges. You got to be really careful with challenges, and you have to be prepared for anaphylaxis because that can happen in situations, especially with nuts and seafood. Those are the two big ones in food. So that I still think, Jesse, that Dr. Sherrard, I'm sorry, I still think that challenge, that history is the most important diagnostic tool. The skin test really serve to confuse you. I think there are probably more false positive skin tests with foods than real, than real values. So I don't value skin test as a single diagnostic tool to identify foods, because I've seen certain children put on such restrictive eliminating diets based upon tests that they were in danger just from malnutrition. So consequently, it's that history. To make the definitive diagnosis, you need to challenge. And in challenging, then you can get together the kinds of things you need to do to intervene. Because intervention with food allergy involves giving small amounts of food over a period of time to reduce the sensitivity.
Thank you so much.
One other question that I have, it'll take just a minute, Dr. Lenore. In autoimmune disease, you mentioned we deal with a lot of allergies, but I had a patient who was coughing. It was an adult, just coughing so badly that they would actually be out of breath and was afraid to drive on the freeway because he thought he would, pass out. And I asked him to just go on an elimination diet of soy, dairy, wheat, and what's the other one? Soy, dairy, wheat, and eggs for 2 weeks or 3 weeks. And do you know that the coughing disappeared totally? And he had been coughing for months, like 8 or 9 months. So how do you explain that?
Well, I think you identified some things that caused him to be reactive. That's the hardest thing to explain. Usually that kind of coughing is an early symptom of asthma of some sort. And it must have meant that the foods that you eliminated, one of those foods was causing him a problem. That further reinforces what I've said about diagnosing food allergy. And you have to diagnose it from the history of a response. I mean, it's just like sometimes when I give albuterol as both a diagnostic and therapeutic trial to see if the coughing responds to a bronchodilator. And if it does, then you know what you're dealing with. If it doesn't, then you need to pursue it more aggressively. What you probably did was identify one of the things that was causing him coughing. I think what's unique about some of this situation now, just as an aside, and I don't know what's happening in Los Angeles, but I can tell you what happens up here. The nature of the viruses change pretty much every year. Here in the Bay Area, what happens now is children get the infection, and the infection disappears, but they cough for the next 2 or 3 weeks. And that cough does not respond to albuterol. So what you've done is identified something that was causing him to have probably some bronchoconstriction. And eliminating that probably is what he needed to have happen.
Can you speak a minute about the various types of inhalers?
Well, yeah, I think that basically 3 types of inhalers. One is albuterol. That's what we call a rescue medication. And so it's used on a limited basis in acute situations. It is not a maintenance medicine. The second set of medicines of that type are salmeterol, which is not used by itself in any type, but used in combination with a third type, which are the inhaled corticosteroids. So drugs like, there are certain drugs that combine both long-acting bronchodilators, which should never be used alone, with inhaled corticosteroids. Symbicort is an example, Dulera, another example. Those by itself. Those are 2 medicines which are combinations. And then there are third types of medicines that combine 3 components, an inhaled corticosteroid, a bronchodilator, and also a muscarinic for patients with COPD with reactive airway disease, drugs like Trilogy, which are used in those circumstances. Those are the 3 main types of inhalers. Then there is the big, on the market, there is a drug called Primatene Mist, which is probably one of the most dangerous drugs on the market. Because albuterol, somaterol, the ones we've talked about, are pure beta agents. Primatene Mist is an alpha and beta agent. So it has not only some effect on the lung, but also effect on the heart. Most of those drugs that we talked about that are rescue drugs or long-acting beta agonists, those are primarily beta drugs without the cardiac component. And so those three areas, one is the beta agents, two is the combinations of long-acting beta agonists and inhaled corticosteroids, or there's inhaled corticosteroids alone. And the third are the other drugs that are used for COPD with primarily a reactive airway component.
Dr. Lenore, I'm so glad you included Primatene Mist in your discussion of inhalants, because every time I see the commercial on television, I cringe. I personally have lost a child, to Primatene Mist, and the actors in all of the commercials I've seen, I'm not saying these are the only ones they make, but the only ones that I've seen have all had Black actors in them. And I feel like our community is particularly at risk because it's an over-the-counter drug, and people, want to, I don't want to say take a shortcut, but they don't want to take the time to go get their prescription refilled or get a new prescription, and they go and get Primatene. So I'm really happy you brought that up.
We tried to keep it off the market for years. It was off the market for quite some time, but repurposed, and now it's available.
Dr. Lenore, it's kind of late in the talk, but can we just go back and cover some real fundamentals for our layperson audience? For example, including like what are some of the more common ways that allergies manifest themselves, like common symptoms, but also how the chronic lack of treatment for them can impact, the overall quality of your life, your mental and emotional health as well, right? Because it can affect your sleep patterns and how well you're thinking, irritability, those kinds of things.
Well, you just did all my work for me. Explained everything. You're right. I think you also, and not just look at it, the primary organ systems that are affected are the upper airway, the lung, and the skin. Those are the three types. I mean, obviously, when you have anaphylaxis, that's a total body kind of response. And so that's not, I think, beyond the scope of this discussion. But what's also important about that is that there are secondary problems with that. Let's just take allergic rhinitis. If you have constant allergic rhinitis, obviously the ears drain into the nose, the sinuses drain into the nose, and so consequently you can have these secondary problems associated with the primary problem. So that's the first thing. If you have a skin problem with eczema, for instance, usually you can get a lot of impetigo and serious skin infections. And obviously, if you've got asthma, there are all kinds of consequences to that, all of which have the capacity to change the quality of life. And so consequently, allergy symptoms, pretty simple: runny nose, itchy, watery eyes, cough, asthma, and certain skin problems. But it's these secondary problems that can also get you into trouble. Now, what makes that so critical is that now we have a number of drugs called biologics, which is particularly important in three areas. The number one diagnosis that I've seen in my practice through the years is urticaria. And urticaria is almost never allergic. If it is
What is
allergic,
urticaria, doctor?
it's hives. Hives. That's the term. I see more hives than any other allergy diagnosis because it's so refractory. People have trouble dealing with it. And so for these categories, let's just take eczema. We now have some biologics like Dupixent, which you can give to patients with eczema, and it's tremendous in controlling that particular problem, especially for your patients with very serious eczema. Dupixent is a miracle drug. It's also one of many miracle biologics that are for severe intractable asthma, although I find less use for them because most of the patients I have with severe intractable asthma weren't doing the things I told them to do in the first place. And so consequently, to jump to a biologic in that kind of patient would be inappropriate. If you talk about food allergy, there was an article in a New England Journal a couple of weeks ago that talked about the use of Xolair for children and adults with food allergy. Very effective in those studies that were demonstrated. And so these are drugs that we don't get as often. I mean, if you look at the number, we work. I neglected to mention that I am the chairman and president of the African American Wellness Project. That is a project that deals with health equities after you're sick. Because if you look at those situations that I see, it's mostly, for instance, to take prostate cancer, I won't get too distracted in this. If you take veterans and you do everything for prostate cancer that the white patients get, I mean, from screening and study and MRI biopsies and all of that, Black patients do better with prostate cancer. Same thing is true with breast cancer and other forms of things. So the same thing is true with these biologics. We don't get these biologics. I mean, I see patients with horrible eczema who've been to the dermatologist who, for white patients, would have given them Dupixent in a minute. But they're not offered the same medications. And in terms of these biologics, that's another part of it. And so it's not just the allergy symptoms that patients need to be aware of. It's these secondary symptoms, because they're nowadays, with these secondary symptoms, we have new forms of therapy that are not really being utilized as much in the African American community as they should be, just on a statistical basis. I ramble a little bit about that because I'm so upset about that. I mean, we started this 20 years ago because I'm so enraged when I see that Black patients are never treated the same way as white patients. I don't care what we talk about health equity. It's not going to change until that changes.
That's a good point. Good point. I know we got some other questions, but I have one in the meantime. Who should use an EpiPen?
Anybody who's had a history of anaphylaxis should use an EpiPen. The patients that an EpiPen, for the people who don't know, is the treatment for severe systemic allergy that's associated with certain things like drugs and foods and in certain circumstances. Here's what happens, and here's what the statistics tell me, is that most patients who have these major reactions consider Benadryl the first drug of choice. And if you have a severe anaphylactic reaction, the Benadryl is not going to help you. Because by the time you get Benadryl, you're already in the ICU. Because what happens with anaphylaxis, for people who don't know what the disease is, it's a total body allergy reaction, which results in vasodilation, increased capillary permeability. And so the biggest problem is with shock. And so because you use third spacing fluid or bronchospasm because the patient can't breathe. And I can't tell you how many times children and adults have been given Benadryl instead of epinephrine. Anybody who's had a major anaphylactic reaction should carry epinephrine. It should be the first drug of choice. It cannot be overused. But I can tell you, year after year, we see tragedies because people will use steroids and Benadryl in the first phase of this reaction. So I say to people, if you're carrying epinephrine, you need to know not only about the epinephrine, but about the beginning of symptoms as you slip into darkness for whatever reason. I think most of us clinicians have seen patients who have anaphylaxis with no apparent cause. But anybody with anaphylaxis or a history of anaphylaxis should be carrying epinephrine.
Dr. Stevens, anything in the chat?
There was a question from Dr. Lawson who wanted to know, what do you tell animal researchers who develop rodent allergies?
Well, we tell them, they're in cases where it's a serious they're dealing only with rodents, and that's a major part of their career. They can be desensitized under certain circumstances. Any mammal can be desensitized. The problem is that there's so few of them that we don't have a commercial extract. But in those situations where patients, people are working with animals that are not, your pets around the house thing, then we can make extracts for them. that are, pure extracts of the materials that they're reacting to.
I just want to add that Dr. Lawson put in the chat that I think as a result of his research-induced rodent allergies, he decided to go to medical school. And the world is better off, Dr. Lawson.
I tell you, living in California, when my girls first went to Howard, the first thing they saw was rodents, and their solution was to come home.
Dr. Lenore, could you add a little piece to your discussion of anaphylaxis? We've been talking about food and nuts, but there's a class of medication that many in our community receive, and some of it is kind of related to the health equity thing, but there are certain high blood pressure medicines that are known to cause anaphylactic reactions in African Americans. Would you comment on that, please?
Yeah, they're basically what we call anaphylactoid reactions.
Anaphylactoid.
Basically, it's not an immune situation. It's a situation in which, for some reason, they just don't tolerate the drug, and the drug has an adverse effect. And so, but the one thing that does bring up is the number of people who claim they're allergic to penicillin who are not. I mean, that's probably the biggest category of drugs that we have to deal with, because usually something happened when they were little and they don't remember, and they got a rash, and the doctor told them they were allergic to a penicillin. And so that then denies them penicillin, and in a certain percentage of patients, cephalosporins, because there's some kind of cross-reactivity. And we test for penicillin all the time. And in point of fact, the guy I trained with, Dr. Lou Mendelson, invented the peptide that we use to test for penicillin allergy. Very effective test. So what happens is that this thing about I'm allergic to penicillin follows them through their whole life, through all their clinical conditions. In addition, you can demonstrate that they're not allergic to penicillin, but it still follows them because nobody takes it off the record. And so when you talk about drugs, there are lots of drugs that you're right. Some are anaphylactic, penicillins, and mostly antibiotics do report anaphylaxis in some patients. But there are anaphylactoid reactions in which you have very similar symptoms, like with lisinopril, which is kind of the one everybody has the most problems with, that don't have an antibody-antigen interaction, but cause all of the same symptoms of anaphylaxis. And you have to be anurticaria, and you have to be very careful. Like I said, the patients that are most difficult to manage, and that I see most often as referrals, are patients with urticaria or hives. And lots of them have had those hives for years because of the whole situation. With nobody ever trying to ask what drugs they're taking or what they're doing. I can't tell you how many times we've taken people off those drugs and they've gone back to a more normal lifestyle. But the penicillin situation is something that, somewhere back when you were a kid, you had a rash, they told you were allergic to penicillin, and there's been no documentation, no history, no challenges. And we can now do a pretty good analysis of whether or not you're allergic to penicillin. Most of the time we skip the test and go directly to amoxicillin challenges, and 90% of the people don't have any positive reactions to penicillin.
Somebody wants to know, how do you get the penicillin allergy designation removed from your chart?
How
do you do it?
Oh, you have to tell your doctor, and he really has to. They say, look, take this off my chart, because otherwise they never think to do that. But you have to take it off your chart. If you think that there's a likelihood that you really had penicillin allergy, then you should get tested.
So Dr. Lenore, this has been great. I certainly appreciate you taking time to be with us today with such a depth of knowledge. And this was so good. We want to make sure in the future you come back and join us.
I'll be glad to. I would like to ask, that you consider at times listening to our podcast. We have a podcast called Black Doctors Speak. We also have a YouTube channel, as you do, and we do a lot with blackdoctor.org as well. We also, I hate to sound like the hyperactive child, but that's why I broke your toy, because I was hyperactive. But But we also are on radio stations and soon in Los Angeles, Sacramento, and in Chicago, Atlanta, in the Bay Area, and soon to be in Washington, D.C. and other places. So with our 1 minute tips, but our podcast, Black Doctors Speak, we probably have about 40 podcasts on almost all the diseases that impact Americans, but particularly how those diseases uniquely impact Black Americans. Black Doctors Speak on any podcast channel.
Well, thank you. Appreciate it. You're one of the most distinguished physicians we have, and past president of the National Medical Association. We're quite honored.
But I would share with your audience. It wasn't always that way between me and Dr. Maxey. We go back a long way. Sometimes we can have a Black Health Trust on just that.
There you go.
Thank you so much for
Say
inviting me, and congratulations
words,
on all the work you're doing.
Thank you, man. Thank you. Final words, Dr. Hines?
Again, thank you, Dr. Lenore, for all these, like I said, very timely comments and just some clarifications, right? I think that people oftentimes, because of their over-the-counter medicines available, people are oftentimes doing these things on their own. So this was really helpful. And thank you for stressing the importance of environmental modification. I think sometimes that is not emphasized enough. So thank you for your time.
Dr. Wilkes.
Dr. Lenore, thank you so much for not only what you talked about with respect to allergies, but also demonstrating and sharing the passion that you have around the area of health equity and the need for health equity. It's such a pervasive issue in healthcare for people of color, especially African Americans. And I really appreciate someone of your scholarship continuing to be so active in that area.
Well, thank you very much for that compliment.
Thank you. Dr. Neighbor-Stevens.
Thank you, Dr. Lenore. I, like the others, are extremely grateful that you shared your time with us today. And I hope that sometime in the near future, especially before the fall, you could come back and let's get into the whole issue of asthma and asthma medication adherence and the whole 9 yards that drive anybody who treats asthma crazy. Because it's, again, something that is extremely prevalent in our community, and we need to make sure folks know what they need to do. Thank you again.
Thank you.
Let me just jump in, Dr. Maxey. Dr. Hines put the Black Doctors Speak site into the chat so folks can pull it out of the chat or they can click on it there.
Okay, thank you so much. Simon, thank you so much. Everybody have a great Sunday. Thank you again, Dr. Lenore.
Good day, everyone.
Bye.